everyone. Hope all of you stay safe. And first, thanks to CARE Winter Hematology Update 2021 for inviting me to this meeting. My name is María-Victoria Mateos from Salamanca, in Spain, and I will update you about the latest data coming from US 2020 in multiple myeloma. This is the outline of my presentation, and I will start doing a brief review about the goals of treatment for patients with multiple myeloma, followed by the management of newly diagnosed myeloma patients, and I will finalize with the review of the most recent data in the relapse and non-refractory setting. These are my disclosures. And concerning the optimal treatment goals for patients with multiple myeloma, no important changes, and we know that the depth of the response, the longest the progression-free survival, as well as the longest the overall survival. So we have to try our patients to reach minimal residual disease negative if possible, and we have usually evaluated the minimal residual disease inside of the bone marrow using next generation flow or next generation sequencing, but now PET-CT allows us to evaluate the minimal residual disease outside of the bone marrow. And this is an abstract presented at us, and utilizing the Deauville score in multiple myeloma, patients included in the Forte study achieving complete metabolic response presented with a better outcome than for patients who did not reach complete metabolic response. And when we combine complete metabolic response with a minimal residual disease negative into the bone marrow, these techniques will allow us to identify a subgroup of patients with excellent prognosis. This means that the response criteria published by IMWG in 2016 are valid, and we have to try to utilize them as much as possible, incorporating the evaluation of the measurable residual disease. And one important concept, we have to evaluate not only the measurable residual disease at a specific time point, but how the MRD is sustained over time. And in line with this, is an abstract presented at us evaluating the role of sustained minimal residual disease negativity at 1 year in a couple of clinical studies conducted in the elderly population, as well as in the pooled population. And the main message is that when patients achieve the sustained minimal residual disease negative for at least 1 year, the progression-free survival is significantly better. And I think that this is a time to point event that we will evaluate and we will utilize more and more over time. What about the newly diagnosed myeloma patients? As 2020 confirms that induction followed by transplant with or without consolidation and maintenance continues being the optimal approach for this population. In terms of induction, we know that 3 drug-based combination were the standard of care, and now the incorporation of the monoclonal antibodies can be done, and VTD plus daratumumab is a new standard of care that we can utilize as part of induction as well as a consolidation. But really, as 2020, I think that contributed to address these open issues. Is it possible to reserve transplant at relapse? What is the role of consolidation, and how are we going to improve? In terms of the first question here, you can see a phase 3 randomized study conducted by the French group together with the Dana-Farber Cancer Institute and published in New England Journal of Medicine 2017. And transplant was basically compared with the no transplant after induction with 3 cycles induction with bortezomib, lenalidomide, and dexamethasone. And the non-transplant arm included the administration of 5 additional cycles of RVD. The primary endpoint of this study was met significant benefit in terms of progression-free survival for the transplant arm. But when the follow-up is very long, almost 90 months, you can see how there is not any significant benefit in terms of overall survival, indicating that maybe transplant is equivalent to continuous therapy with bortezomib, lenalidomide, and dexamethasone. However, you have to know that, as I previously said, the PFS is longer for the transplant arm, point number one. And the point number two is that almost 90% of the patients allocated to the non-transplant arm did receive it at the moment of the relapse. And this can maybe explain the lack of benefit in overall survival. I personally consider that transplant in the upfront setting is better. And in fact, when this study evaluated the minimum residual disease negativity rate, 30% of the patients receiving transplant achieve MRD negative. And you know in the left part of the slide how this translated into a significant benefit. There is another important phase 3 clinical study conducted by the European Myeloma Network in which the same question was addressed: transplant versus consolidation with VMP. And in this case, the induction was bortezomib, cyclophosphamide, and dexamethasone. And this study had shown before benefit in terms of progression-free survival for the transplant arm. And as 2020 indicated how transplant resulted also into a significant benefit in overall survival, progression-free survival too, as well as time to next therapy. The benefit in overall survival in this study could be explained by the study design, and CyBorD was the induction regime, what is, from my point of view, not so optimal as bortezomib, lenalidomide, and dexamethasone. And in addition, VMP was the consolidation in the control arm. And maintenance was also given as continuous therapy, and this is a main difference with the French study. And some patients even receive tandem autologous stem cell transplantation. But in this slide, you can see how the European Myeloma Network clearly addressed the question of a transplant upfront versus at progressive disease, and there is a clear benefit for the role of transplant in the upfront setting. And one important consideration in this study, only approximately 1/3 of patients who did not receive transplant upfront received it at the moment of progression or relapse. This is the fourth study, another study including carfilzomib as part of the induction, in which transplant was also compared with no transplant. In this study, KCD transplant KCD was compared with KRD transplant KRD and KRD 12 cycles without transplant in between. And this updated presented at ASH showed how KRD followed by transplant resulted in the longest progression-free survival, clearly superior to KRD 12 cycles or KCD, including autologous stem cell transplantation. And again, when we evaluated the proportion of patients achieving MRD and sustained over time, KRD incorporating transplant was the schedule or the scheme, resulting in approximately 70% of minimal residual disease negative. So it is possible to reserve transplant at relapse. I would say that transplant continues being standard of care as part of the first line of therapy. It's true that the lack of benefit in overall survival after RVD induction makes possible to consider some patients' preferences, but we have to inform to our patients that it is better to do earlier on than to reserve at the moment of the relapse. And maybe in the future, we can consider the risk status as well as the minimal residual disease status in order to ask or in order to plan another question: transplant, yes or not, but no transplant in the upfront setting versus at the moment of progression disease or at the moment of the relapse. What is the role of consolidation? And the European Myeloma Network addressed again this question, and after transplant or VMP, patients were subsequently randomized to receive consolidation with RVD versus no consolidation. And in terms of quality of the response, on the intent to treat patient population, consolidation, upgrade the quality of the response, and finally translated into a significant benefit in terms of progression-free survival. And this was basically applicable to both VMP or transplant arm with a hazard ratio of approximately 0.8. You know that these data are a bit contradictory with those reported by the Stamina trial in the US, but when we look at the PFS from the second randomization, the hazard ratio was sustained across the different subgroup of patients, and I decided to remark here the best response induction mobilization intensification before consolidation to see how patients achieving complete response or extreme complete response, the hazard ratio was higher than 1. And maybe this can be helpful in order to correctly address this question: in which patients should we prescribe consolidation after transplant? Maybe in those patients in which we consider that we are going to be able to upgrade the quality of the response. And if this is not the case, maybe we can go directly to maintenance therapy. How are we going to improve? Definitely new combinations, new 3-drug-based combination, plus the monoclonal antibodies are coming. Transplant continues being standard of care, and as 2020 brought up some information about a new maintenance scheme: daratumumab single agent, daratumumab plus lenalidomide, or carfilzomib plus lenalidomide. The information about dara maintenance is really very limited because this is the Cassiopeia study, and the second part of the study included a randomization to dara monotherapy versus observation, and the data were not presented at us. And just to show you this press release announced at the end of the month of November, indicating that this second part of the study met the primary endpoint, and dara monotherapy is able to prolong the progression-free survival in comparison with observation. Another possibility is to combine lenalidomide with daratumumab, and this has been addressed in the Griffin study, a phase 2 randomized study, and we have here the information coming from dara VRD as induction, post-transplant, post-consolidation, and after 1 year of maintenance, and 82% of the patients achieved a complete response, a proportion significantly higher than that observed with RVD alone and lenalidomide as maintenance, 61%. But in the Griffin study, minimal residual disease was evaluated, and the intent to treat patient population, 63% of the patients receiving dara RVD achieved MRD negative, whilst only 27% in the control arm. And again, the proportion of patients who were able to sustain the MRD was significantly higher for dara VRD, followed by dara len as maintenance. Definitely, this is a phase 2 randomized study, and we have to wait to the results of the phase 3 randomized study being conducted right now by the European Myeloma Network. Another possibility is to combine carfilzomib with lenalidomide, evaluated in the Forte study. And after the induction, transplant, and consolidation, there was a second randomization: len alone, carfilzomib, and lenalidomide. And the addition of carfilzomib was able to convert in up to 46% of the patients the MRD positive into negative, and at the end, there is a significant benefit in terms of progression-free survival. So new data in terms of management for transplant-eligible newly diagnosed myeloma patients. What about the non-transplant eligible population? Dara VMP continues being a standard of care, and the Alcyon study showed a significant benefit for dara VMP in terms of PFS and overall survival. And at ASH 2020, we had the opportunity to see how, again, the progression-free survival was significantly longer for those patients achieving the best quality of the response, at least complete response, or even complete response and a minimal residual disease negative, confirming the prognostic impact of achieving minimal residual disease negative. And Also, there is a clear relation between the quality of the response and the quality of life. And patients reported a better global health status when they achieve a complete response and when the minimal residual disease was negative. Another possibility is to focus on Lendex, and Lendex plus data was updated at ASA 2020, but before showing you the update of Lendex data, I would like to show you this phase 3 clinical trial, Tourmaline MM2, in which the oral proteasome inhibitor ixazomib was added to lenalidomide and dexamethasone. And this phase 3 randomized study showed a clinically meaningful benefit in terms of overall survival for ixazomib, lenalidomide, and dexamethasone, but unfortunately, the difference was not statistically significant. The trial did not meet its primary endpoint, and personally, I think that is a bad news, but I'm not sure if we will be able to utilize ixazomib Lendex as part of the treatment for elderly patients in the upfront setting. Dara Lendex versus Lendex as continuous therapy evaluated in the Maya study has been updated at ASH 2020, and Saji Kumar showed how after a median follow-up of 4 years, the benefit continues being demonstrated for Dara Lendex. Median progression-free survival not reached yet, and the control arm Lendex resulted into a median PFS of 34.4 months, what is exciting from my point of view and longer than expected. The subgroup analysis of progression-free survival showed how the benefit is consistent across the different subgroup of patients. And I would like to remark the benefit in patients with high-risk cytogenetic abnormalities, because the hazard ratio for progression-free survival in the high-risk subgroup of patients is 0.57, and the median PFS for patients receiving Dara Lendex was of approximately 45.7 months. And I think that this median progression-free survival for this specific population is quite exciting. And I would like to remark this factor because we know that median progression-free survival usually in patients with high-risk cytogenetic abnormalities usually is shorter than that reported here. The Maya study showed also the benefit in terms of progression-free survival too, and this is going to be a surrogate marker for the benefit in overall survival we will see with longer follow-up. And after this information focused on newly diagnosed myeloma patients, I will move to evaluate the latest news for relapsed and non-refractory myeloma patients. These are the European guidelines published in 2017. Definitely these guidelines are old guidelines, maybe not from the practical point of view because of the approvals and reimbursement issues we have sometimes to consider these guidelines. But from the scientific point of view, I think that we have to move to new guidelines because basically almost all patients are going to receive proteasome inhibitors, IMiDs, and lenalidomide as continuous therapy as part of the first line of therapy. So most patients will be len refractory, some patients will be CD38 exposed, some patients will be CD38 naive, and I think that we can distinguish at first relapse between combinations based on CD38 monoclonal antibodies or combinations based on non-CD38 monoclonal antibodies. In pink, you can see the combinations evaluated basically in phase 3 clinical studies. And the first new combination is KD plus daratumumab, evaluated in the Candor study, presented 1 year ago and updated this year. There is a significant benefit in terms of progression-free survival. The median PFS for KD data was 28.6 months versus 15.2 months, what is important, and the hazard ratio was 0.59. But I would like to remark the benefit of KD data across different subgroup of patients, especially those refractory to lenalidomide, median PFS 28 months, and the effective or the efficacy in the len refractory population was sustained for those refractory after just one prior line of therapy, 25 months, or 2 or more prior lines of therapy, 28 months. So this is a new standard of care we can potentially utilize in relapsed and refractory myeloma patients. And another possibility is to switch the monoclonal antibody from daratumumab to isatuximab, evaluated in the IKEMA study. Update also at us, benefit in terms of PFS has a ratio 0.53, median PFS not reached yet, and the minimal residual disease evaluation in the IKEMA study put in context how up to 1 out of 3 patients receiving KED plus isatuximab achieved minimal residual disease negative, and in the right part of the slide you can see how the deeper the response, the longer the progression-free survival, and basically this is a flat for those patients achieving MRD negative. Another combination is dara plus pomalidomide and dexamethasone, evaluated in the phase 3 clinical study Apollo, in which the control arm was pomalidomide and dexamethasone. Significant benefit for POM-DEX-DARA in terms of progression-free survival, median 12 months versus 6.9. And in principle, we can say this combination seems to be less effective than KD plus the anti-CD38 monoclonal antibody. You have to realize that although this study was conducted in relapsed and refractory myeloma patients after just one prior line of therapy, only 11% of the patients were treated just with one prior line of therapy. This means that most patients were treated after at least 2 prior lines of therapy, and this can explain this progression-free survival. And when we utilize this combination more and more in the real life, the efficacy data will be maybe better. Dara POM-DEX resulted also superior in terms of overall response rate, as well as even minimal residual disease negativity rate. Toxicity profile is acceptable, and it's nothing new in comparison with the known safety profile for both dara as well as pomalidomide. If we decide to move to the non-CD38 based combination for this population, I am not going to show any slide about PVD because this is a new standard of care not updated at ASA 2020. VD plus selinexor, evaluated in the Boston study, was already presented at ASCO and EHA 1 year ago, showing the significant benefit for the addition of selinexor to bortezomib and dexamethasone. And at ASA 2020, we had the opportunity to see how the superiority of selinexor, bortezomib, and dexamethasone was sustained across the different subgroup of patients treated with 1 or 2 or more prior lines of therapy, previously exposed to bortezomib, or even previously exposed to lenalidomide. And just to remark the significant benefit with the acceptable toxicity profile when selinexor was used at a dose of 100 milligrams once per week in combination with bortezomib subQ, also once per week. And within these new guidelines, it is possible also to optimize the combinations I've just shown you based on data from phase 2 clinical studies. And we had the opportunity to see some of these possibilities at ASA 2020. This is one of them, evaluated in this phase 2 clinical study conducted by the Canadian Myeloma Group. And relapsed and refractory myeloma patients were randomized to receive dara in combination with cyclophosphamide, dexamethasone, and pomalidomide versus dara, cyclo, and dex, with the possibility of adding pomalidomide in case of progressive disease. In principle, when we evaluated the progression-free survival, it is better to utilize the 4-drug-based combination since the beginning, although it's true that the PFS significantly improved when pomalidomide was added at the moment of the progressive disease. I consider interesting the sub-analysis conducted in the population receiving lenalidomide as part of the last line of therapy. I can imagine that all these patients or most of these patients were len refractory and daracyclodex plus pomalidomide resulted in a median PFS of 27 months, significantly superior to daracyclodex alone. But in this population, when pomalidomide was added, the median PFS improved up to 24 months. Just to mention the toxicity profile, because neutropenia and infections are a bit higher than expected, and maybe it is necessary to consider the use of GCSF as well as prophylactic antibiotics in order to prevent these infections. DARA can be also combined with ixazomib and dexamethasone. This is a phase 2 clinical study conducted by the Greek group. A small sample size, promising data. All patients were treated with lenalidomide as part of the prior line of therapy, most of them refractory, and the PFS is of approximately 1 year. And another possibility is to utilize KD plus cyclophosphamide, evaluated by the Spanish myeloma group with two important considerations. First, when we add cyclophosphamide to KD, the benefit was mainly observed in patients refractory to lenalidomide with a median PFS of 26 months. And the second important consideration, carfilzomib was given just once per week, what is definitely much more convenient for the patients. Let's move on now to the third and subsequent lines of therapy. And it is possible to utilize pomalidomide-based combination, especially if the patients have not been previously treated with pomalidomide, although personally I consider that pomdex plus isatuximab or ilotuzumab will move to early relapses if available. You know that belantamab mafodotin is so far approved for relapse and refractory myeloma patients after at least 4 therapies, including PI, IMiDs, and anti-CD38 monoclonal antibodies. And we have here other new molecules like selinexor plus dexamethasone, as well as melflufen. And personally, I consider that in the future, at the third line and beyond, it would be possible to select maybe selinexor, melflufen, or belamaf, and to combine with drugs that patients had maybe received before, like monoclonal antibodies or pomalidomide. And some examples have been presented at us. Selinexor in combination with pomalidomide and dexamethasone, not in heavily pretreated myeloma patients, and the median number of prior lines of therapy was 3. But when we combine selinexor, pomdex in earlier lines of therapy, there is a significant benefit. Overall response rate is 60%. And also it's important to remark that selinexor was given at a dose of 60 milligrams just once per week. And this translated in a very positive safety profile with a very low incidence of gastrointestinal toxicity, as well as even thrombocytopenia with this combination of grade 3-4. And in terms of outcome, the median PFS for all patients included in this study was of approximately 1 year. Another possibility, melflufen plus dexamethasone in combination with daratumumab. And again, small sample size after a median of 2 prior lines of therapy, but this combination showed an overall response rate of 73% with a median PFS of approximately 1 year. We have to take care about the toxicity profile because the incidence of grade 3-4 thrombocytopenia is quite high, 73%, as well as neutropenia, and we have to take care about infections, and especially 2 patients who died from fatal sepsis. And another possibility is belamaf in combination with pomalidomide and dexamethasone. And this is also an interesting study because when we move earlier on, median number of prior lines of therapy 3, the overall response rate for this combination significantly is much more better than for pomdex alone or belamaf single agent. And in the intent to treat patient population, the overall response rate was almost 90%. PFS is immature. Median PFS has not been reached, but in the 3 drug class refractory population, again, the median PFS was 1 year. But another important data is that the different doses and schemes for belamaf were evaluated in this study. And although the conclusions are not very solid yet, it's important to see how the overall response rate is quite maintained utilizing different doses and schemes, and it's important to see how from the safety point of view, belantamab given at a dose of 1.92 milligrams per kilo resulted in a very low incidence of keratopathy, only 25%, with changes in the visual acuity in only 17%. So I think that all these presentations open the door to new combinations, and this brings us to a new third model, iberdomide, evaluated in this phase 1 clinical study in combination with daratumumab or in combination with bortezomib, heavily pretreated myeloma patients, and in fact, in both cohorts of patients had been already exposed to daratumumab and even refractory to it in the iber-daradex, and the same for the iber-bortezomib and dexamethasone. And the overall response rate is quite encouraging, and iberdomide will be utilized for sure earlier on in first lines of therapy, early relapses, and in combination with the different backbones. Let's now briefly to focus on the BCMA targeted therapy in the third therapy, but before entering into the CAR-Ts and bispecific antibodies, just let me show you a new antibody drug conjugated, MEDI2228, presented at us. The mechanism of action is similar to belamaf, but the cytotoxic agent is different. And the population evaluated here included 82 patients, but 57% were triple class refractory. The overall response rate was 66% with a median duration of response of 6 months. So data are encouraging, but you have to realize that the population is similar to that included in the DREAM-1. So these results are not basically comparable with belamaf in the DREAM-2. As antibody drug conjugated, some ocular toxicity, photophobia was reported in this phase 1 first in human study. And now let's move on to evaluate the CAR-T cells as well as the bispecific monoclonal antibodies. This is a busy table in which you can see a summary of all autologous CAR-T cells presented at ASH meeting, and I would like just briefly to focus on ide-cel, evaluated in the CRB401 clinical trial update at ASH 2020 with the significant data in terms of overall survival of approximately 3 years for heavily pretreated myeloma patients. What is the explanation? CAR-T cell therapy can potentially modify the biology of the disease. Clones emerging at the relapse are completely different and may be sensitive to the rescue therapies, and this can explain the benefit in overall survival. We don't have the answer yet, but the data are promising. BB2121 ide-cel evaluated in the KarMMa pivotal phase 2 clinical study. Basically, these are the data presented at ASCO with a benefit or an overall response rate of 73%, median PFS of 1 year in the highest dose cohort, and patients achieving complete response, median PFS of 20 months. But ASH 2020 informed us about the sustained benefit across the different subgroup of patients, and especially in the high-risk subgroup of patients, extramedullary disease, cytogenetic, high tumor burden, but the only exception were RISS3 population. And the chronological age should not be a limiting factor for prescribing CAR-T cells, and in the KarMMa-2 trial, patients older than 65 and older than 70 were included, and the efficacy was maintained. And one important information, the quality of life reported for the patients were exciting and comparable or similar to the health population. And I think that this is an important consideration. Cilta-cel, evaluated in the CARTITUDE-1 study, was also updated at ASH 2020, now with a large series of patients, almost 100 patients, heavily pretreated after a median of 6 prior lines of therapy, 88% 3-drug class refractory, almost all of them refractory to the last line of therapy. And in this situation, the overall response rate was 96% and the complete response rate 67%, with a substantial proportion of patients achieving minimal residual disease negative. Follow-up is short enough, but at 1 year, 76% of the patients remain alive and free of progression. And I think that these data are quite encouraging and very relevant from the management point of view for patients with multiple myeloma. In terms of toxicity, CRS as expected, eye cancer toxicity as expected, as well as hematological toxicity, and only to report that some additional neurotoxicity emerged in a small subgroup of patients occurring later on than the icon toxicity, and the median time to recovery was also longer than the other icons toxicity, and investigation is ongoing in order to try to predict and to manage this neurotoxicity. But the quality of life and perceptions from the patients included in the CARTITUDE-1 were also very positive. And I think that this is an important consideration when we consider the possibility of prescribing CAR T cells for our patients with multiple myeloma. I am going to briefly show you the other autologous CAR T cells, but utilizing this summary slide because of the time limitations. BB21217 tried to enrich the leukapheresis product with more naive stem cell memory and central memory T lymphocytes in order to increase the peak of expansion as well as the persistence, and in principle, the preliminary data are positive. LumiCAR is a fully human CAR T that will avoid immunogenicity and improve the safety profile and maybe the efficacy. And data reported from a cohort of patients included in the US showed also very promising data from the efficacy point of view, but also from the safety point of view. Prime BCMA 101 utilized a different manufacturing process because this transposon mechanism does not require the use of lentivirus. And in addition, they utilize for the leukapheresis a piggyback, enriching also the product with stem cell memory T lymphocytes. Sample size is quite small, but data are very preliminary, very positive, especially in terms of a safety profile. And the dual CAR T targeting BCMA plus CD19, really positive data, but in my personal opinion, I am not able to dissect what is the real benefit of the addition of the CD19. Just a couple of slides for the allogenic CAR T, because this would be the ideal situation. This study included the use of anti-CD52 in order to prevent the rejection of the CAR T, as well as the elimination of the TCR in order to minimize graft versus host disease. 31 patients were included in this study, and data are promising, although it's true that the overall response rate from my personal point of view is lower than expected. Toxicity is excellent with a very low rate of CRS as well as ICANS and no graft versus host disease. And when we evaluated the expansion, we can see how patients included in the highest dose, the expansion of the CAR T seemed to be disappearing at least approximately at 2 months after infusion of the CAR T. Definitely, I think that the data are immature and maybe we have to wait to have longer follow-up. I will focus on the BCMA CD3 bispecific antibodies just with this slide because a long list of bispecific monoclonal antibodies were presented at ASH meeting. I would say that in terms of a population was quite comparable across the different studies, and approximately 60, 70, up to 80% of the patients were 3-drug class refractory. In this situation, the response rate is quite positive, and the range can be between 60 and up to 80% of the patients achieved at least partial response, with some patients, approximately 20% of them, achieving complete response. However, the data are not very mature, and in fact, we don't have any data in terms of durability of the response, as well as progression-free survival and overall survival. From the safety point of view, CRS is also present in almost all of these studies, but the incidence is lower than with CAR-Ts, most grade 1 and 2. Neurotoxicity is also present, but at low rates than CAR-T cells, and cytopenias or infections are also present with these bispecific monoclonal antibodies. How are we going to differentiate all these BCMA bispecific monoclonal antibodies? First, in terms of efficacy, although as I previously said, we don't have a mature data yet in terms of durability of the response. Safety profile seems to be quite similar, so the key aspect to differentiate them in terms of practicability, I would say that included the route of administration, IV versus sub-Q, the schedule of administration, weekly versus every 2 weeks or even monthly, what would be much more convenient, as well as the number of priming doses, if it is required priming doses, yes or not, and the number of hospitalizations the administration of these bispecific monoclonal antibodies will require. You know that while this BCMA targeted therapy today is allocated in relapsed and refractory myeloma patients already exposed to PI, IMiDs, and anti-CD38 monoclonal antibodies, but the BCMA targeted therapy landscape is quite crowded, and fortunately, as 2020 showed us at least 2 new targets in myeloma, GPRC5D with talquetamab, a bispecific monoclonal antibody, evaluated also in relapsed and refractory myeloma patients after at least 6 prior lines of therapy. Results are encouraging with overall response rate in the recommended dose phase dose cohort, 405 micrograms per kilo sub-Q, 70%. Safety profile comparable to the other bispecific monoclonal antibodies. And just to mention that GPRC5D is expressed on the hair follicle, and it does not induce alopecia, but we have observed some injection site reactions, rash, and nail disorders. And another new target is cevostomab, targeting FcRH5, and also evaluated in 53 relapsed and refractory myeloma patients. And one important consideration, both talquetamab and cevostomab included already patients treated with a BCMA targeted therapy, CAR-Ts, bispecific, or conjugated monoclonal antibodies. The efficacy is again quite promising with a similar safety profile, and definitely this is something good in order to incorporate into the landscape of treatment for patients with multiple myeloma. This is the summary from us 2020 for the relapse and refractory situation. And I would say that the choices at first relapse are going to be clearly influenced by the late refractory, as well as that are exposed or naive. The choices at the second and subsequent relapses, my first choice would be BCMA targeted therapy, but new targets or new molecules like melflufen and or selinexor are interesting in order to be combined with monoclonal antibodies or IMiDs. And from my personal point of view, the challenging situation is what is the optimal sequencing and how the landscape will evolve over the upcoming months or over the upcoming years. And I stop here. Thank you very much for your attention.